Hi, this is Matt from Akin Gump, co-host of OnAir Healthcare. Thanks for listening to this episode with Kyle Zebley of the American Telemedicine Association. We wanted to preface this episode with a small contextual note. We intended to run the episode before the election, but circumstances dictated that we're releasing it now. Because we recorded it earlier, there might be one or two references to what might happen in the election. But that aside, all the other content is timely and, thanks to Kyle, extremely thorough. And of course, as I record this note on November 28th, we still don't know the full outcome of the election, and we don't know what Congress is going to do on telehealth. Hopefully, this episode will provide you some insight on that latter point. Thanks, and on to the show. Welcome to another episode of OnAir Healthcare, the Akin Gump healthcare podcast that gets at the intersection of policy, politics, and healthcare. I am Matt Hittle, a senior policy advisor here at Akin Gump.
And I'm Ramirez, a consultant here at Akin Gump. And I'm super excited that we're coming back for our second season of this podcast, Matt.
Yeah, we decided to do seasons when I was out for 3 months with a little baby. And so it just worked out nicely. A congressional recess, people actually have time to listen.
Great. Congratulations, Matt.
Hey, thank you very much. We have a wonderful episode today. We've got Kyle Zebley, who's with the American Telemedicine Association, here with us today to talk about the word that's on everybody's lips, telehealth. Kyle has a distinguished career here in D.C. He started out in the office of Congressman Tom Price, a member of the Ways and Means Committee in the House of Georgia. He moved then over to the Department of Health and Human Services. He was head of the Office of Global Affairs, which is a pretty neat position. And then he moved over to the American Telemedicine Association. Now with ATA Action, a new organization. Kyle, welcome to the podcast.
It's great to be here. Thanks so much, Matt.
Of course. Why don't you give us a little bit of a taste of Kyle Zebley beyond the bio?
Well, like you said, been here in Washington, D.C. for 13 years and always been a lifelong passionate advocate of good policies and loved politics from a young age and married and try to travel as much as I can. And it was great that COVID's over now that can go beyond my living room into other corners of the country and the world.
Well, it's a pleasure to have you here, Kyle, and it's a pleasure to know you and have known you for some time.
Absolutely. I should. Yeah. And another interesting thing beyond my bio is that I knew Matt way back when we both worked in Congress and ran into each other in the House gym and ran into each other in the back rooms of the Ways and Means Committee as well. So
in the House gym where we were both lifting 550 pounds.
Easy to start. And then you kind of worked up from there. Yeah.
Podcast math. Well, let's jump in. We've got a really meaty topic here today, obviously telehealth. And so this can get really complicated. A lot of our listeners are probably familiar with it, but let's kind of set out a base of information and go from there. So as many folks know, the rules that are related to the provision of telehealth are based mostly in the Medicare program. And Medicare is such a big payer. It's so influential. It effectively sets the standard for the rest of the healthcare system. Medicare, under normal circumstances, will generally not pay for telehealth unless certain criteria are met. And some of these include, for example, a requirement under which Medicare will reimburse for telehealth only when it is furnished at an approved location, generally not in a patient's home. Additionally, in some circumstances, Medicare will only pay for telehealth if a patient physically visits a healthcare provider for an initial visit first. So under the COVID-19 public health emergency, most, if not all of these restrictions were temporarily waived, in part to prevent patients from physically visiting healthcare providers when they didn't need to keep the facilities available for those people who had COVID and to stop the spread in those facilities. So the catch, though, is that these flexibilities go away upon the conclusion of the public health emergency. The Consolidated Appropriations Act of 2022 did contain a provision to extend those flexibilities for 151 days, which is about 5 months after the expiration of the public health emergency. But after that, it's anybody's guess. So if Congress declines to further extend those flexibilities at the end of those 151 days, those pre-pandemic Medicare restrictions will snap back into place. So with that base of information, Kyle, what is ATA and ATA Action pushing for? And do you think there's a realistic opportunity for action at the end of those 151 days?
Well, hopefully there's going to be action well before the end of that 5-month window. But as you know very well, Matt, of course, Congress tends to only really act when they're back is up against the wall and they have no alternative. I am very optimistic. We have broad bipartisan support. We are really lucky to be working on an issue as the ATA and ATA Action, where we had friends on either side of the last inauguration day. President Trump implemented and working with Congress to do so a lot of those public health emergency flexibilities that you had talked about at the beginning that lifted those geographic and originating site restrictions that are embedded in law. The Biden administration has been as great on these issues as the Trump administration has been. We've got all the right support in Congress. We've got strong bipartisan and bicameral support. There's the right piece of legislation out there that would really make permanent a lot of these PHE flexibilities that we seek to make sure folks have access to after the end of the pandemic, after the end of the public health emergency. So it's really a question of when, not if, in my mind, that the vast bulk of these will eventually get to permanency. But in the meanwhile, Congress might have us sweat it out a little bit, and we might be in a circumstance that's not unfamiliar to Washington, D.C. and to advocates, where we might have a few more extensions in store for us prior to it finally getting to that permanent place.
So Kyle, I just got back from the American Telehealth Academy in Nashville. And one of the things that really struck me was this divide in how sort of people inside the Beltway look at telehealth legislation and what the rest of America thinks, is necessarily going to happen with telehealth legislation. But there are a lot of bills that have come through Congress. Some have been circulating for years, including things like the Connect for Health Act, but then others that, have more recently passed the House. What does the ATA look at as far as telehealth legislation goes? And are there particular things that you support, other things that maybe you oppose?
Well, there's no major piece of legislation out there right now that we oppose. And you're right, there are a number of bills that do different things that would go a long way towards meeting our goals. There's something like the Connect for Health Act, which is mostly focused on those Medicare-related flexibilities and which would make those flexibilities permanent. Obviously, that's something that we're extremely supportive of. It's a bill that, like you said, has been introduced. Many Congresses running. Right now, it has a filibuster-proof majority of the supermajority of senators that have signed on as co-sponsors. It shows you just how far the telehealth community has come in terms of the support that we've got. There's the recent passage of H.R. 4040 in the House of Representatives that was introduced by Congresswoman Liz Cheney and was bipartisan in nature, like all these bills tend to be. And it was co-sponsored by Representative Debbie Dingell of Michigan. And it would extend until the end of 2024, most of the flexibilities that have come about during the pandemic. It passed overwhelmingly in the House at the end of July, 416 to 12. We're hoping that the Senate will take that up. And actually, we hope not only will the Senate take that up, but we're hoping that it will include provisions that were left out of H.R. 4040, like the high deductible health plan tax provision that makes it easier for the 35 million Americans that have HDHP healthcare. It would allow them to have inducements to use telehealth. Also, there's a really important issue to the ATA, which is the ability for those providers that have prescribing authority to remotely prescribe controlled substances without an in-person requirement, the Ryan-Haight Act waiver, that has allowed for this huge cohort of patients to receive clinically appropriate care wherever they are. That's been in place, like these other PHE era flexibilities, since the beginning of the pandemic. It is set to expire actually when the PHE ends, unlike so many of these other flexibilities that have that 5 months that would be in existence for 5 months post-PHE that Matt had talked about. So we hope that the Senate will act on responding to HR 4040 and go further. There are also things like the acute hospital care at home program that will expire at the end of the PHE, items like telehealth as an accepted benefit that will expire when the PHE ends. So we have a number of asks. There's the right bills out there to make it permanent. It's just a question of getting Congress to bundle it all together. Finally, I'll just say, while there's lots of bills that we're supportive of, there's lots of provisions that we want to see action on. We know how Congress works. All too often, it does end up being relatively last minute, like I had said in response to the last question. And also, really, it tends to be in a kind of omnibus bill or a comprehensive piece of legislation that's seeking to address other things that are expiring. So we're obviously very supportive of getting ourselves attached to any moving piece of legislation that would get Congress to actually pass it into law.
Well, staying on that topic, I know all the Hill staffers and former Hill staffers listening they know what's coming next. If there's anything on Capitol Hill that makes members of Congress sing Kumbaya, it's telehealth. However, Congress has yet to coalesce around a specific policy other than that 5-month extension. And it doesn't take a genius to know that cost is part of that reason. The Congressional Budget Office, by way of background, which analyzes legislation to examine its cost or estimate its cost to the federal government, says that telehealth is very, very expensive. CBO's cost estimate for that 5-month extension was $663 million, and the Committee for a Responsible Federal Budget extrapolated that to about $25 billion over 10. That HR 4040, which you mentioned, Kyle, costs something like $2.5 billion. And there's been a lot of ink spilled on this topic. And I think the question is the assumptions CBO uses to get to those high cost estimates. Where do you come down on this? I suspect I might have an idea, but what are you telling folks right now when it comes to those high costs? And is CBO wrong in the way that it estimates telehealth costs?
Well, CBO has a hard job in front of it, and obviously it's a running game in Washington, D.C. to quibble with the CBO. That goes back to my time working for a member of Congress who was chair of the Budget Committee and still struggled to get CBO to change some of its analysis to be a little bit more dynamic, which was a real challenge, has been a long-running challenge. I think one of the things that we have seen CBO respond to is the fact that it is actually continually shrinking down the number that's attached to extending these provisions. So anything like a $25 billion over 10 years, I think is a rather outrageous sum. Doesn't really take into account the new normal rate of utilization that's come down a good deal since the peak at the beginning of the pandemic, when we were trying to keep, like you had said at the beginning, people out of emergency rooms, out of hospitals, out of an environment where they might infect themselves and others with COVID-19. That's when telehealth was maybe upwards of 52% of all reimbursed medical encounters in the Medicare program. It's come down significantly since then. And what we have seen is, in large part, this is care in lieu of what would have been in-person care rather than additive care. And also, if you look at what has happened and who these providers were actually seeing, it tended to be patients with whom they had already had pre-existing relationships. And so it's really helped accentuate and maintain the continuum of care rather than being what some people just have a feeling is the case, but we don't think is borne out by the facts, which is additive care and care that's going to be growing the costs of Medicare reimbursement.
And do you think, Kyle, is there any risk with a potential price tag like that Congress approaches this more of like a sustainable growth rate type saga where, they kind of intermittently intervene, but don't really sort of come with an all-out fix from the get-go?
I have used the SGR analogy myself, maybe just because of bringing flashbacks from my time on Capitol Hill. As you recall, the SGR dynamic, which isn't exactly analogous, but it's something that's often pointed to, resulted in 18 years of kicking the can because of the cost associated with it. Obviously, we're nowhere in the same ballpark as the SGR in cost, but I don't think you're wrong that the dynamics might be replicated in that we might be in store for another few extensions. Like I said, Congress tends to go down the path of least resistance, and that might mean that we've got a couple of extensions in store prior to permanency, like you had suggested. So I think it's a very fair analogy, even if this particulars might be a little different.
Let's kind of back up and look at the industry wide. Obviously, to Republicans' delight and Democrats' chagrin, I think the president recently declared the pandemic over. But the White House has walked that back. But it does represent the reality for many people, maskless, walking down the street, maskless in Ubers now in Washington, D.C. So it's hard to imagine the administration is going to pursue many additional extensions of the PHE unless there are some serious issues this winter. So if that PHE expires and Congress fails to pass legislation, what are the implications for this industry that has had quite a bit of investment over the past couple of years? And what's the contingency plan for these providers and other companies that have made these investments?
Well, a couple of things in direct response. That's a great question. One is, of course, that the administration is committed to following the science, as they have said many different times. And so the pandemic's not behind us. My wife and others that I know are just getting COVID for the first time. So it's hardly something that's over. We know that there have been big COVID surges over the last two winters. It wouldn't be mistaken to think that we might be in store for yet another surge here over the next couple of months. And if there is, I would fully expect the administration to extend the PHE again. That being said, this is no way to run a healthcare system in terms of that long-term and certainty and the long-term certainty that folks want in order to make these kind of sustained investments. And so that's why we think there's no time like the present for Congress to act. If Congress were to fail to act and the PHE were to end, and let's say that the PHE might end after the next extension, which could be in mid-January, we do have that 5 months in place for most of the Medicare Part B fee-for-service flexibilities that would allow us to continue to make the case that there shouldn't be any backsliding towards a place in time prior to the pandemic. That's where we were, where only a small, minute number of Medicare beneficiaries had access to reimbursable care. As you had noted, if the PHE expires and that 5 months worth of flexibilities end and Congress has not acted, then we'll go back to a place in time where Medicare Part B beneficiaries have to be within a defined rural area and within the four walls of a provider's office in order to receive reimbursable virtual care services. We'll have gone off that telehealth cliff, and folks that have access to clinically appropriate care now will lose access to it. And that's, I think, a real shame. It'll be a real step backwards. It'll mean that Medicare beneficiaries don't have access to all of what is technologically possible and clinically appropriate in the 21st century. That being said, and that is a dire situation, it's an unacceptable situation. I don't think it's one that the administration and the Congress would allow to transpire. Even if that were to come to pass, telehealth is here to stay in so many other ways. Medicare Advantage has all sorts of flexibilities that mean that the Medicare beneficiaries that receive their care through Medicare Advantage plans would continue to have access to virtual care services. At the federal level, you look at other programs that have coverage and reimbursement of telehealth, such as Indian Health Service and TRICARE for active duty military personnel. The Veterans Administration has robust coverage and reimbursement of telehealth services. If you look at the state front, just about every Medicaid program in the country reimburses some variation of telehealth, particularly audiovisual synchronous telehealth. And if you look at commercial coverage across the country, there has been robust and sustained investment to the point where it's very much a permanent fixture of commercial coverage plans. And then finally, of course, we have our direct-to-patient, direct-to-consumer providers that are out there who at a very reasonable low cost are delivering all kinds of clinically appropriate services remotely to patients across the country. So Medicare, huge thrust of our federal advocacy. It covers millions of Americans, and it does set the standard for what so much else is done in the U.S. healthcare system. But that is not the only way that people are receiving access to telehealth services now. And even if all those flexibilities go away, there's lots of different ways that folks can maintain that access.
Well, and Kyle, one of the areas that maybe has gotten more attention recently, as things with the pandemic have started to taper off a little bit, I think early in those early stages, people were getting all of their care through telehealth. There has been, I think, an ongoing push in the mental health space and the ability of telehealth to kind of expand access to those resources and that help during a time in American history that's been particularly stressful for many Americans and many people. But one thing that has gotten, I think, more press lately, though, is the prescribing of some medicines that have not traditionally been prescribed through telehealth. And I'm thinking about some of the different psychotropic drugs or other things. And, I think there's a lot of disagreement about whether or not a virtual platform is really the safest or the most appropriate venue to prescribe some of those drugs. Tell us a little bit about what you guys think and how should we approach that aspect of it?
Well, at the end of the day, telehealth is healthcare. It's not something separate and apart. And the same standard of care that applies to a provider practicing in person applies virtually. And if the standard of care is not being met virtually, then that licensed medical professional has violated the terms of their license and is subject to scrutiny from both federal authorities and state authorities. Indeed, they could lose their license. They could go to civil or criminal adjudication if they've improperly prescribed a controlled substance, in direct answer to your question. So there are layers of accountability in place at the federal level and the state level that should allow folks to understand that this is not the Wild West, that it continues to be an extremely well-regulated aspect of the overall healthcare industry. We think at the ATA and at ATA Action that the ability for licensed medical professionals to prescribe clinically appropriate controlled substances without an in-person requirement that has been in effect during the pandemic has been a great success. It has meant that more underserved and vulnerable populations have had access to that clinically appropriate care. We think it should be the new status quo, and we think that Congress could do that through legislation, or the administration could do that through something that they have been instructed to do by Congress now for 14 years, which is through the Drug Enforcement Administration, implement a special registration rule that would allow for licensed medical professionals with the prescribing authority in good standing to register with the DEA and continue for the remote prescription of controlled substances. Just as there are challenges in in-person care and mistakes that are made or like negligent decisions that are made in person, so too, of course, that can happen virtually. But there is every capability in place with federal authorities and state authorities to bring to justice those kinds of providers that are not abiding by that really important standard of care.
Well, continuing on the theme of potential malfeasance, the HHS Inspector General recently released a report that said that, broadly speaking, telehealth doesn't seem to pose a high risk to Medicare. But the IG also said that there's no systemic way for CMS to identify those providers with improper billing practices, despite the fact that those folks are generally connected to larger entities that also have troubling billing practices. So if Congress decides to pursue telehealth flexibilities in a more permanent way, what do you think CMS should do in terms of preventing improper payments, preventing fraud?
Well, CMS and HHS and the Office of the Inspector General at HHS have a lot of processes already in place to determine at what rate CMS will reimburse for services and the accountability measures that need to be in place to make sure that the taxpayer is getting value for that money. The same standards that are applied to in-person care obviously are extended to virtual care services, and that should continue. And that report, I think, as you noted, did show an extraordinarily small number of inappropriate and questionable reimbursements, even during this massive expansion of telehealth services during the pandemic. Well less than 1% of payments raised questions from the Office of Inspector General as they looked into the data. And so really, let's not come up with new guardrails that would be solutions in search of a problem. And instead, let's continue to allow for access to clinically appropriate care services. Now, if there's other kind of identifiers that can give greater peace of mind to the great folks at OIG or at HHS in terms of ensuring accountability for the taxpayer dollars, then the ATA and ATA Action will be all supportive of it, provided that it's not another barrier to access to care. The worst type of guardrail imaginable are in-person requirements that aren't clinically appropriate, are barriers that are more difficult for certain underserved populations versus others, and that don't allow for the full potential of telehealth services. So barring the implementation of those kinds of guardrails, we're very open to look at any other new suggested guardrails. That being said, we don't think we should be handled in a different way that puts us at a higher standard as compared to in-person care.
Well, and do you think, Kyle, is the uncertainty around some of this, is that influencing, or are you guys seeing any impact to provider adoption of sort of wider spread telehealth platforms? One of the sort of themes that came up when I was down in Nashville was our ability to try to turn telehealth not into just a sort of standalone care platform, but really like a hybrid offering that health systems fully integrate into the sort of offering that they deliver for their patients. And I know that the ATA has kind of an implementation framework that you guys offer to health systems to help assess whether they feel like they're ready to sort of utilize telehealth in different sort of capacities. But to what extent do you think the uncertainty is influencing the ability to adopt that model right now?
So we've seen a massive expansion of the adoption and implementation of telehealth since the beginning of the pandemic. As such, it really is now a permanent part of the healthcare landscape, even with the uncertainty that's been engendered by these temporary federal policies or perhaps the expiration of certain telehealth flexibility policies at the state level. So even with that regulatory and policy uncertainty, we've seen tremendous gains and a tremendous maturation of this industry, such that I don't think there's a major healthcare system in the country that doesn't have a very robust telehealth program that's moving and transitioning towards more of a hybrid care model, as you suggest. So we're seeing tremendous levels of investment and a huge degree of permanency for telehealth. That being said, there's no question there are virtual care services that are not getting as much investment as they would if we had permanency for the Medicare program, if we had a greater permanency in some of the states in regards to the ability to use every modality possible in the best interest and in the benefit of patients, for instance. So as we start really, I think, hopefully clearing up this low-hanging fruit of obvious policies that we need to have, we can then start really thinking about some of the harder and stickier issues around making a true hybrid model possible, a truly interoperable healthcare system possible. But first, we've got to take care, like I said, of this low-hanging fruit of just so many obvious decisions that policymakers should make. And once we do have that permanency, I do think it'll drive even greater investment.
Kyle Zebley of the American Telemedicine Association, it's been a pleasure having you.
Thanks so much. It's been a real honor. And like I said, it's great to be working with you all at Akin Gump. And I'm a little biased, my wife being an associate there. So thank you so much for all that you're doing. Yeah, absolutely.
Thanks, Kyle.
Thank you.
A really fascinating episode, Mario. It was really cool to hear about. Obviously, there are quite a few folks in the healthcare industry that are really focused on continuing the pandemic flexibilities. And Kyle is obviously a wealth of information. I will note that I inadvertently gave him a promotion in one of his past jobs at the Office of Global Affairs at HHS. He wasn't the head, he was the chief of staff, but still influential nevertheless.
So, well, it's interesting. So I actually just learned that Kyle and I came from that same office. I was a director of their pandemic and emerging threats division before him. So Kyle and I actually had more in common, but you're right. It's super fascinating, discussion. I think the discussion around like sustainable growth rate model is particularly interesting to me. Seeing how split and how divided Congress is, it's hard to see this getting across the line with just a giant funding bill, but I'm always a little skeptical. So what do you think, man?
We will not know until 24 hours before it comes out. That's how things have been working. And I think that's probably how things are going to continue to work. Hammered out negotiations, although, I could be wrong. There's a lot of time between now and the end of the year. So time will tell. We will obviously provide our listeners any updates we hear. If you'd like to get in touch with us for any ideas for new episodes, you can email us. Again, this is Matthew Hittle, a senior policy advisor here at Akin Gump.
And I'm Mario Ramirez, a consultant here at Akin Gump.
And I'd like to extend a word of thanks to Sean Feely, policy advisor here at Akin Gump, who works with us on the podcast. He's been on before, and he's just invaluable. So thanks to Sean. This has been another edition of OnAir Healthcare. We'll catch you next time.
OnAir with Akin Gump is presented by Akin Gump and cannot be copied or rebroadcast without consent. The information provided is intended for a general audience and is not legal advice or a substitute for the advice of competent counsel. Prior results do not guarantee a similar outcome. The content reflects the personal views and opinions of the participants. No attorney-client relationship is being created by this podcast, and all rights are reserved.